This video is Self-Diagnosis Reviewing the Literature Part 3. So this is Part 3 of my attempt to review every single academic paper published on self-diagnosis. There's no reason to listen to Parts 1 and 2 in advance. I'm not reviewing the papers in any particular order. If you want to see what I've already reviewed, I have a bibliography of papers on my website with a link below to this, which contains a list of papers I've reviewed and a link to the actual video. This paper is Self-Diagnosis of Psychiatric Conditions as a Threat to Personal Autonomy, published in Philosophical Psychology in 2024. The author is Ilir Isufi, which I'm almost certainly mispronouncing, so I apologise about that. Isufi aims to argue that, quote, this trend of self-diagnosing carries a risk of undermining one's autonomy understood as self-governance, end quote. This is because misdiagnosis leads to people having an inaccurate understanding of themselves, which then leads to a reduction in autonomy due to a disordered self-image. So Isufi is going to give reasons to doubt that self-diagnosis is typically accurate, and then outline a potential negative consequence of this. The paper starts by outlining the diagnostic manuals, then outlines autism and ADHD, including how they're diagnosed in clinical settings and challenges to accurate clinical diagnosis. Isufi then moves on to self-diagnosis, outlining that they are addressing the accuracy of self-diagnosis measured by the current diagnostic criteria, rather than considering the legitimacy of self-diagnosing individuals modifying the diagnostic criteria when self-diagnosing. Isufi outlines how information on social media is often misleading, whereby symptoms of a diagnosis are given a simplistic or inaccurate description. There is also the problem that some diagnoses require knowledge about what someone was like as a child, but Isufi points out evidence which suggests people often interpret their childhood in light of how they think of themselves today. People also have cognitive biases whereby they unconsciously start interpreting evidence in a way that supports their preconceived view. Isufi also outlines how diagnoses can overlap with one another, whereby the same symptom can occur in multiple diagnoses, which makes accurate self-diagnosis even harder. Having outlined why they think self-diagnosis can be unreliable, Isufi then considers whether inaccurate self-diagnosis can be harmful. Isufi outlines Sarifi Tenkin's notion that psychiatric diagnoses function as a narrative which supplies concepts for people to understand themselves. This typically involves a reassessment in light of a diagnosis, whereby they might understand their characteristics, their past life, and their present situation in a new way. As I understand it, there is a lot of evidence that this occurs when somebody receives a diagnosis. However, Isufi suggests that if this reassessment is based upon an incorrect self-diagnosis, then this can reduce autonomy. Their understanding is no longer based upon a potentially accurate self-perception, but is instead based upon a misperception, which then reduces their capacity to make informed choices. This is a reduction in autonomy because they are less able to make choices which align with their values. Isufi gives an example of how somebody who mistakenly thinks they are autistic purposely avoids social situations, ends up isolating themselves and avoiding situations which challenge them, which might mean they miss out on meeting new people or career advancement. Isufi also gives the example of someone who thinks they're ADHD stopping paying attention to an admittedly boring reading or lesson, even though they have the capacity to keep it paying attention, and so they don't learn something valuable. At the same time, Isufi does admit the opposite might occur, whereby if the self-diagnosis is reliable, accurate self-diagnosing could increase self-understanding, which then increases autonomy. Isufi outlines two potential solutions to this. Firstly, social media companies could ban any content relating to self-diagnosis. Isufi rejects this solution because it, quote, could conflict with freedom of expression and provoke accusations of censorship, end quote. Also, there is a problem that official diagnoses are so expensive that, if I read Isufi's views correctly, self-diagnosis is potentially legitimate as a last resort. Finally, there is a problem of working out exactly which social media content is harmful, especially in relation to videos which involve awareness raising about psychiatric diagnoses, but without actually stating that self-diagnosis is as legitimate as official diagnosis. The second alternative, which Isufi considers, is for self-diagnosing videos on social media to come with warning labels. Isufi outlines how videos on COVID-19 always had a warning label which gives a link to a reliable source of information. Doing this in relation to self-diagnosis would mean we don't have to work out which videos are harmful since all videos relating to self-diagnosis get the label. Also, it involves much less censorship than banning these videos and empowers users by giving them access to reliable information. As such, Isufi recommends putting warning labels on self-diagnosis videos rather than banning them. So what did I like about the paper? I think it makes a very convincing connection between self-diagnosis and autonomy. Accurate self-diagnosis can increase autonomy, and inaccurate self-diagnosis can decrease autonomy. Since self-understanding is an important aspect of autonomy, of being able to make well-informed decisions, there is a clear link between self-diagnosis and autonomy. Also, Isufi makes a nice suggestion about putting content warnings on social media videos relating to self-diagnosis. This is a nice middle ground between banning misleading videos and letting misleading videos remain accessible. Isufi nicely highlights how we could add them by giving the example of warning labels which are placed on videos relating to COVID-19. Without wanting to suggest that I think Isufi's suggestion is the best approach, I do think the paper makes a well-argued-for case for something which is worth considering and which I had not seen other people suggesting before. Isufi's suggestion might be wrong, I don't know, but the paper gives a clear case for a specific position which advocates of self-diagnosis can respond to. As for what I disliked about the paper, well, nothing really. Okay, the paper does come down pretty heavily on self-diagnosis being typically inaccurate, and I don't know if that's true, although having tried to read everything published on self-diagnosis, I also don't know that it's false. There certainly is significantly more empirical data that suggests self-diagnosis is inaccurate compared to data that suggests it's accurate, but whether those papers are actually any good is a question I'm trying to establish by reviewing them. Ultimately, Isufi takes a stance which they back up with evidence and argumentation, and I cannot see any obvious problems with, even if advocates of self-diagnosis are likely to think the evidence Isufi offers is flawed. Overall, it's a great paper. This article is Patient Self-Diagnosis, Physician Engagement to Compete with TikTok by Dorothy E. Stubb. It was published in 2025 in the journal Focus. Stubb explores in this article how mental health professionals should engage with people who self-diagnose. Stubb starts by outlining increasing levels of social media usage and content relating to mental health on social media. Stubb says that social media posting increased by 80.5% during the pandemic. She also says that much of this information is unreliable, citing a study which claims that 83.7% of mental health advice on TikTok is misleading. There's also the problem of, quote, algorithm-induced confirmation bias, end quote, whereby the more you look at content on a particular topic, the more you see content on that topic. This means you start missing out on other potentially relevant information that could give an alternative explanation. Stubb highlights all of this with a lengthy clinical hypothetical situation, which imagines a mother and a daughter having a psychiatric evaluation. The daughter thinks she fits the diagnostic criteria of multiple diagnoses, whereas the mother disagrees. The mother says the daughter is obsessed with social media and is just copying what she sees on there to get attention and try and fit in. The daughter responds that the mother refuses to believe there's something wrong with her daughter, and the mother should just accept her daughter for who she is. Stubb then considers some potential solutions to these issues. Given how heavily people hold on to their self-diagnosis, with Stubb suggesting that some go to great efforts to remain in the sick role, mental health professionals need to have empathy, validate their distress, and have an attitude of curiosity without then having to actually validate the self-diagnosis. She also suggests that self-diagnosis serves different purposes to different people, and mental health professionals should work out which purpose is a case for a particular person. This could then allow individualized assessments and care plans without endorsing the self-diagnosis. Care, however, is needed not to reinforce the common concern among self-diagnostic communities that the professional cannot be trusted. Stubb then outlines many tips for, quote, enhancing engagement with a patient who presents with egosyntonic self-diagnosis, end quote. Egosyntonic is where something is central to self-perception, so she means people who see their self-diagnosis as a crucial part of who they are. So here's some ways Stubb suggests to engage with people whose self-diagnosis is important to them. understanding the patient's opinions and concerns with empathy, providing recommendations rather than just a diagnosis, highlight that the same symptom can be seen in multiple diagnoses, highlight that people have a complexity which cannot be reduced down to a diagnosis, ask open-ended questions, take a clinical history, take a history of their social media usage, assess the patient's online presence, i.e., what they're doing online, formulate a case which outlines the role that self-diagnosis is playing, and allow feedback from the patient. Stilp also makes some recommendations which include discussing other types of communities in diagnostic communities which someone could engage in, such as community groups, volunteering, and sports. So, if somebody is self diagnosing because they're seeking a community, well, there could be other types of communities they could seek instead that aren't based around diagnoses. She also mentioned suggesting some social media free time to clients and that parents talk to their children about their social media interactions. So, that's what the article says. What are the strengths? Stubb makes the suggestion that we can validate various aspects of an individual without also validating the self-diagnosis. So we can listen to and take seriously the concerns and beliefs held by the individual, try and understand who they are and what their situation is without then endorsing their self-diagnosis. This is potentially good advice to a mental health professional if, and I emphasize if, we take self-diagnosis as unreliable. We might not consider someone's self-diagnosis as being accurate, but we can still potentially validate other aspects of them. This is also useful if we believe people have a good understanding of their own symptoms, because someone might have a really good understanding of what symptoms they exhibit, but that doesn't mean they then understand which diagnosis they have, given that the same symptom can occur in multiple diagnoses. Now, potentially, an advocate of self-diagnosis might say that someone's self-diagnosis is so central to them that disregarding it would be massively invalidating. If so, the claim that there's a way in which we can validate someone without also validating their self-diagnosis would not work. That argument might be right, I don't know, but until that argument is convincingly made, then Stubb has made a useful suggestion. Another positive is that Stubb points out that people self-diagnose for different reasons, and mental health professionals should aim to understand why they have self-diagnosed. As for weaknesses of the article, it does seem to assume that self-diagnosis is unreliable without providing much evidence for this. Also, some of the evidence it does cite is from a blog post. Given that the article is short, I don't think it needs to try and prove that self-diagnosis is unreliable, but I do think it could have instead took a stance of, let's assume self-diagnosis is unreliable, and then let's explore what approach mental health professionals should take given that assumption. Doing this would make the article less partisan and would be more accessible to people who are more agnostic about the legitimacy of self-diagnosis. So the next paper is Self-Diagnosis in the Age of Social Media, a pilot study of youth entering mental health treatment for mood anxiety disorders. It is published in Acta Psychologia in 2025, and it is by Sarah Armstrong, Elizabeth Ush, Michael Worms, Owen Cheevler, Stephanie Keifler, Medina Medui, and Lauren Rice. As ever, apologies for mispronunciations. The paper aims to establish whether young adults who suspect they have a diagnosis use social media to find out about the mental health condition. It also aimed to understand which specific social media websites were used and assess whether those sources had reliable content about psychiatric diagnoses. This helps establish whether people who self-diagnose are basing their self-diagnosis on reliable information about psychiatric diagnoses. The authors outline the trend of people getting information about mental health and psychiatric diagnoses from the internet, including social media. They mention that previous studies have found that the descriptions of psychiatric diagnoses found on social media are often scientifically inaccurate. The authors outline how social media can exacerbate mental health issues, whereby, for example, social media reduces people's ability to concentrate, whilst also some of those social media sources might be simultaneously suggesting they have ADHD. Similarly, People with depression typically spend longer on social media than people without depression, which might mean social media could be exacerbating the depression. The paper does mention the alternative possibility that people who are depressed or have mental health issues might use social media because they are being excluded by in real life people. Other potential negatives of self-diagnosis include the danger that people might over-identify with a diagnosis, seeing it as an essential part of themselves which significantly constrains who they are when there is actually an alternative means, medical or therapeutic, which might help prevent their problems. Additionally, they may not seek help because alleviating the symptoms means they cannot access online communities anymore, which are based around those diagnoses, since without the symptoms, they no longer have the diagnosis. Finally, the authors draw upon Hacking's looping effect to outline how, when people get a diagnosis, they often think about themselves and think about the diagnosis in a new way. This could mean that people self-diagnosing leads to an expansion of a concept of a psychiatric diagnosis, meaning we see more and more stuff as constituting a diagnosis like ADHD. How did the authors conduct their study? They recruited 57 people. These were prospective patients at a first episode mood and anxiety program in Ontario. The program treats people between the age of 16 to 25 who are experiencing symptoms associated with mood and anxiety disorders. They completed a survey about their social media usage, which covers how often they use social media and how it affected them. They were also surveyed about how important diagnoses are and if they suspected that they had a diagnosis which they hadn't actually been diagnosed with by a professional. Finally, the different sources of information which participants used to learn about the diagnosis were demarcated between based upon their quality. Specifically, there was a demarcation between, quote, sources that resemble legacy media, academically orientated media that is, and social media. Legacy media tends to be more reliable sources of information compared with social media. Academically orientated sources adhere to a tradition of peer review, editing, and journalistic integrity. End quote. So the authors think that academic sources are significantly more reliable than social media. So what results were found? The authors found that of all 56 participants, every single one of them viewed online content about mental health, and 47 of them rated themselves as doing this sometimes, often, not always. The majority of them, 70% of them, never posted on social media about their own experiences of mental health. So they're looking at content, but most of them are not actually posting about their own experiences of mental health. 40 of the 56 individuals suspected that they had a diagnosis which they had not been given. And of those 40 individuals, 21 of them said social media had informed that belief. The authors then listed which sources of online information were most influential. By far, the three resources that were most used in order were TikTok, Instagram, and YouTube. Significantly less popular in order were Wikipedia, WebMD, Google Scholar, and Snapchat. Both of those two were equal, and then Twitter. Significantly lower again was Medical News Today, Facebook, and PubMed. Finally, much lower than all the others was Apple News. Although TikTok, Instagram, and YouTube were most used for mental health content, of those three websites, only YouTube was significantly associated with suspecting that they had a diagnosis. Finally, 24 participants strongly agreed that diagnoses are important, 23 agreed, and 9 were neutral, with no one disagreeing or strongly disagreeing. The level of agreement was correlated with time spent on social media. The main reasons why diagnoses were valued was how they guide treatment and provide insight, and then understanding from others and validation, and then treatment accessibility coming lower and community coming last. So what did I like about the paper? I think it gives a very nuanced study which helps clarify and partly challenge a common complaint about self-diagnosis. Critics often say that self-diagnosis is just a case of people getting misled on TikTok and that they only self-diagnose because they are looking for a community to be part of. This is why self-diagnosis is so inaccurate. This study only partly supports this. Yes, people who self-diagnose are typically much more likely to use social media than more traditional academic sources. However, the main source being used by people who self-diagnose was not TikTok or Instagram, but it was YouTube. So critics are wrong about which website is being primarily used by those who self-diagnose. Also, most people who self-diagnose did not post about their mental health online. So it seems that most self-diagnosing people are not actively engaging in online communities about mental health. This implies that they have self-diagnosed for reasons other than seeking an online community. So whilst the paper does not disprove the critics of self-diagnosis, I do think it suggests the critics are exaggerating their case. So I think this is a really great paper for helping us get some specifics upon what self-diagnosing people are actually doing. Of course, this paper is only looking at a particular population attending a mood and anxiety clinic, so perhaps the critics are fully right in relation to other people who self-diagnose, who knows, but this is still some really useful empirical data. As for things I did not like about the paper, well, I don't think the paper had any significant problems, but I do think there are a couple of missed opportunities. It would have been really interesting to know which diagnoses participants had self-diagnosed with. This would help establish who is using YouTube rather than academic sources or TikTok when they self-diagnose. Also, it would have been really useful to know exactly how much weight people put on their self-diagnosis. Is it the case that most participants had adopted an identity around their self-diagnosis, seeing it as a central part of who they are, interpreting themselves through it, or had most participants a vague suspicion that they might fit a diagnostic criteria, but had not actually reinterpreted who they are through adopting a self-diagnosis? Demarcating between these two positions, and of course there's many positions between them, would help demarcate between suspicion of a diagnosis and a commitment to a diagnosis. Which of these positions constitutes self-diagnosis is debatable, but I think making this demarcation would enrich the empirical data. This paper is Negotiating Normalcy, Epistemic Errors in Self-Diagnosis Late-ADHD. It is published in 2025 in Culture, Medicine, Psychiatry, and it is by Alexandra, Brandt, Ryborg, Jonsson. I believe that's how it's pronounced. She hopes to answer, quote, how do ideas about psychiatric diagnoses, particularly ADHD, translate from psychiatric manuals to the everyday lives of people? Specifically, how do adults recognize and characterize experiences as symptoms of late-onset ADHD? End quote. The paper reflects on conversations she had with adults who self-diagnose as ADHD. She draws upon conversations and theory about medicalization to suggest that self-diagnosis can result in an epistemic error. She argues that self-diagnosis partially involves a narrowing down of notions of normality, which then means a greater range of characteristics are considered indicative of divergence from normality. This broadens out what sort of behavior is part of a psychiatric diagnosis. This involves an epistemic error because that behavior might have a non-psychiatric origin, such as due to a stressful life event. Jonsson interacts with 7 people through observations, informal conversations, and interviews about their life story, all of whom self-diagnosed. They were aged between 32 and 42, all were Danish, 4 were female, 1 was male, and 2 were non-binary. They had a variety of social-economic positions. All had self-diagnosed with ADHD, although most of them were waiting for a diagnostic assessment which they hope would confirm that self-diagnosis. Also, Jonsson interviewed 5 psychiatrists about ADHD diagnosis and clinical practice. The results of these interviews were combined with theoretical work on self-diagnosis and medicalization throughout the paper. Jonsson outlines overdiagnosis of ADHD. She defines overdiagnosis as where, quote, individuals are diagnosed despite lacking significant impairment, end quote. Note that this definition explicitly links diagnosis with being impaired, which is an issue I will return to later. Interestingly, Jonsson mentions that what constitutes functioning can vary based on social and cultural context, so they are aware about complexities of notions relating to impairment and functioning. Jonsson suggests that some people who go for an ADHD assessment might instead be depressed or anxious, or just simply have problems with focus and attention. She outlines possible influences on self diagnosis, citing the influence of drug companies, positive portrayals of ADHD by the media, and how the heavy expectations laid on people by workplaces and educational settings can lead to medicalizations. Psychiatric diagnoses are sometimes used to mark the boundaries between normality and abnormality. Jonsson suggests there has been a narrowing of notions of normality due to public perceptions of diagnoses like ADHD. As the public perception of a diagnosis expands, notions of normality shrink, which means more people get counted as impaired. In this way, what is considered the boundary between normality and abnormality influences whether someone is considered eligible for a diagnosis. She outlines this with examples from people who she interviewed. They framed everyday challenges in terms of ADHD, whereas medical professionals typically resisted this interpretation. This means that people who she interviewed are being seen as too normal, which then is a barrier to an official diagnosis. Sometimes people were relieved to hear that they were normal, but the people she interviewed typically felt that they were not being taken seriously. One source of disagreement is that some people Jonsson interviewed were what she called unconventional normality, such as being trans. So far as I can tell, unconventional normality means someone who lives significantly different lives to most people, but without being pathological, so they still count as normal. Some doctors suggested that the struggles of unconventionally normal people might be due to the unconventional elements in their lives. The people she interviewed typically rejected this interpretation since they did not see being trans as problematic. A doctor Jonsson interviewed gave another interpretation whereby somebody facing constant discrimination and structural injustices will have a major toll on their mental health, which then might make them hyperactive or inattentive. Similarly, Jonsson interviewed someone who faced major neglect as a child, but who then thinks their problems relate to self-diagnosed ADHD. Jonsson asked this person whether the neglect might be a better explanation of their difficulties, and the person responded by denying that ADHD is a disease. Jonsson is concerned that this type of reasoning could be an epistemic error. This involves, quote, the false assumption that we can control or manage living systems through quantitative measurement, end quote. Jonsson outlines how someone she interviewed for ADHD is a part of you which is there regardless of culture or society. This way of seeing ADHD involves a, quote, dualistic divide between the individual and their culture or society, end quote. So Jonsson thinks that people who self-diagnose mistakenly think they have a medical issue when actually they are having a natural response to bad living conditions. She thinks that we need to address the wider social issues rather than, quote, reducing their concerns to an identity-related issue, end quote. She feels that expanding what constitutes ADHD shrinks down what constitutes normality and blurs the divide between normality and abnormality. She suggests that we need an eco-social perspective whereby minds, brains, and people interact with wider social and cultural environments. This means there is more to the symptoms people experience than just some isolated brain. We need to understand the wider narrative of people and not reduce them down to a diagnosis. I'm going to, in this case, outline what I liked and what I disliked together, since I feel the strengths of the paper are also related to its weaknesses. The paper basically says that some people who self-diagnose are misinterpreting their struggles, which are actually due to bad social situations, as evidence that they have a psychiatric diagnosis. Jonsson does provide some evidence for this occurring, since some of the people she interviewed did seem to focus upon the diagnosis they self-diagnosed with as the main explanation of their difficulties. Of course, we don't know if their self-diagnosis is accurate or not, but even if their self-diagnosis was accurate, then it seems that, at least on the evidence Jonsson presents, they were downplaying the role of the social environment. So whilst this paper does provide a novel interpretation of self-diagnosis, it does very much portray self-diagnosis as relating to belief that there is a fixed thing in your head, a fixed type of brain which remains the same regardless of your environment. Given that there is so much emphasis on psychiatric diagnoses these days, it does seem plausible to me that this phenomena could be happening more broadly. That being, thinking in terms of psychiatric diagnoses when social factors explain their struggles better. It is fair to say that a lot of psychiatrists are certainly guilty of this. Though, if this is occurring, I know of no evidence that would show it's happening in 5% of cases of self diagnosis or 50%. And of course, there's a possibility that someone could be struggling due to something relating to their diagnosis and bad living conditions. Whilst this paper does provide a novel interpretation of self diagnosis, it does very much portray self diagnosis as relating to a belief that there is a fixed thing in your head, a fixed brain type which remains the same regardless of your environment. Some people may indeed think that. However, I do think that the neurodiversity movement sometimes has a somewhat more nuanced account of how the environment interacts with people who have different brains. I would guess that most accounts of neurodiversity would stress that a person of a particular type of brain can thrive in one environment but massively struggles in a different environment. So, whilst Jonsson is right to say there is a major focus on diagnoses these days, it does seem to me that she downplays how there is also a focus on the role of social environments in influencing mental health. She does mention that some people she interviews understood their self-diagnosis through neurodiversity, but, at least on the evidence she offers, they seem to be focusing on neurodiversity as non-pathologizing and neurodiversity as putting the diagnosis as central to identity, rather than neurodiversity as highlighting the role of the environment. So whilst I do think Jonsson is downplaying notions of neurodiversity which I see in academic writings, I have no data upon the percentage of people who self-diagnose that are aware of the emphasis that neurodiversity places upon social environments, or how much emphasis people who self-diagnose place upon that, if they are aware of it, compared to how much they focus upon psychiatric diagnoses as being this fixed thing in your head, and as a source of identity. Finally, there is a question of how easy it is or difficult it is to work out whether your struggles stem from your psychiatric diagnosis, the social environment, or both. This might significantly vary depending upon which psychiatric diagnosis you consider and what those social factors are. So whilst I think Jonsson raises an important point that does make it a good paper, I also think she does not sufficiently address the neurodiversity of movement. Although, admittedly, which approach is taken by people who self-diagnose is something that, as far as I'm aware of, we don't have any firm evidence on. Jonsson also raises the point that as more people self-diagnose, the more our notions of normality shrink. I think it's great that this has been highlighted as a potential consequence of self-diagnosis, although there's still the question of whether it's preferable to have a broader or narrower notion of normality. Of course, Jonsson thinks that broadening out diagnoses means they are no longer useful, so people who should have a diagnosis are getting less benefit from them, and people who should not get them are actively harmed by having them. Overall, I think the paper makes some novel interpretations about self-diagnosis, which ultimately makes the paper worth reading. However, I do think the paper would have benefited if it looked at some aspects of neurodiversity in more detail. Thank you for listening.